So we've heard a lot about how to pick up on intimate partner violence, what the clinical features are, and what we should be aware of. So when we're juniors and we encounter intimate partner violence cases, what are we going to do about it? What are our management options?
Okay, so there's a lot of ways to look at this issue, but the broad principle is that you need to empower the victim to help herself or help themselves. It's not for you to be making decisions about what that person should be doing because you're not living their life and you're not in that situation. So the first message is to provide information and empower someone to take their own next best step. Intimate partner violence should be viewed as a complex chronic medical condition. And just like a lot of other complex chronic medical conditions, this is something that we are not really equipped to deal with as primary care doctors. So your end game ultimately is some kind of referral. A lot of people feel quite awkward about that. So what, am I just going to give a number of an NGO and that's all I must do? But if you saw somebody with a fractured femur, you wouldn't be the one doing the surgery. And IPV is an incredibly complex situation. So I want you to see it as a complex medical condition that needs to be referred to someone who's really got the expertise. The best end game is an NGO who deals with victims of IPV and survivors every day. We have quite a lot in this country. But then it will also depend on why that patient came to see you, because hardly anyone comes in to say, oh, doctor, I'm being abused by my partner. So they will have come in with whatever symptom complex they have. So you might have to deal with the medical aspects. There are probably going to be some psychological aspects, which you are not going to be equipped to deal with either. But if there's things like STIs or like immediate things that need to be medicated and dealt with, you need to do that. So referral to an NGO or referral to information. So if somebody's got access to the internet, you can refer them to helpful websites. You can refer them to a piece of paper with information on it. I like to include family, well, supportive family and friends in the referral picture, because you would be referring this person to them for care and help. So you should sort of have an idea of whether that person has got anyone in their life who'd be able to help them. In the ward, so in a hospital, most people, if they pick it up, they will refer to the social worker, which is fine. But out in the community, the social workers have got a massive caseload. So it is there again much better to refer to a local NGO outside of the hospital environment to help. What you absolutely must not do and cannot do is instruct the person what they have to do next. And especially, you can never ever tell them that they must leave. And why is that, Danny?
So from my understanding, the highest risk situation is when somebody is trying to leave, and it can often escalate the violence to a point where people are either seriously injured or even killed. So that sort of situation takes a lot of planning and preparation and understanding, and is not something that should be directed by a healthcare provider, but should definitely, if that is the plan, should be something that the patient initiates with after being like fully empowered and having a proper plan in place, so that they can leave safely.
Yes, that's exactly right. In fact, about 75% of homicides, of domestic violence homicides, occur when someone is about to leave or has left. So it does have to be very carefully thought out, and that should be done in conjunction with an NGO who has got the expertise.
And Dr. Gordon, what do you do if at your hospital, perhaps on ComServe, for example, you find out that there isn't really an NGO around you and you don't feel like there's a policy or sort of things in place that you can refer to?
Yes, very valid question. It's a question I asked a lot of the NGOs when I did my research on this, and they said they were quite confident, to my surprise, that there's always going to be a gogo or an auntie or someone in the community who's got a safe house, or somewhere to hide women or help. So it's your job then to find out who that auntie is, and make sure that you link the patient up with that person. And if there really isn't anyone, then you become your own referral system. And what do I mean by that? I mean, you book follow-up appointments just to check in and see how that person is, see whether they're ready to leave yet, see how they're doing. If that's the best you can do, that's the best you can do.
Part of the 6 Rs, when we talk about the crisis plan,
Yes.
so when would you give somebody that information about a crisis plan? Would that not be part of your initial consultation then, or?
Okay, so the crisis plan is a plan that is put together in order to enable someone to leave. So that, in fact, is probably best handled by the NGO, who can oversee that process. But if you see, so one of the most important things that you have to do in the context of IPV is a risk assessment. And if you determine that the situation is a very high risk, you need to communicate that fact to the patient. If there is nowhere that can help you construct a crisis plan, then you can, if you determine that someone is in great danger, or if they want to leave, you can give them information on how to start planning when to leave. Because as we've said, it's got to be done very carefully because it's a very high risk time.
Yeah. So in that case, if our end game is referral, as students or junior doctors, I think we feel a lot of pressure and a lot of responsibility to these patients to feel like we've done something or done enough. How do we know that we've actually made a difference, and how do we ensure that we're doing the right thing for these patients?
Students are going to feel incredibly helpless at times. I don't want you to underestimate the time that you sit with a patient talking to them about this trauma that they've experienced. Because I can almost guarantee you that no one else has ever asked them this question. So just by going there and allowing them to actually vent all of this stuff, that is one huge way in which you can help, even though it feels very passive.
I think in my limited experience, what also tends to happen is that even though we've had all this teaching, when you actually experience your first IPV case in real life, it's still quite overwhelming, and you forget half of this management and you feel like you're not doing anything. So in that case, I think it's really useful to sort of have a basic approach in your mind and just return to basics, maybe even like potentially leave the room for a moment, invent a reason to go and leave, and just sort of think, okay, what am I actually going to do? And just sort of regroup.
Absolutely. I mean, my expectation, the nugget of all of this is that you identify and you refer. And if you know, it doesn't matter how you identify, you know, you're going to forget all the different questions. You're probably going to forget how to ask. You're going to forget the 6 R's. It doesn't matter. Then, yes, you go out the room, you have a look, you come back in. But the point is that you were sensitized enough to think about it. And that's what I want.
Mm-hmm.
The whole of medicine is going to feel overwhelming. You're going to have so many cases as young doctors that are just going to blow your minds because they're so emotionally taxing. IPV is definitely one of those areas. But I don't expect you to fix it. I expect you to identify and refer. That's all you can do. That's what I do as a seasoned professional. That is what I do still to this day.
Thank you so much, Dr. Gordon.
Sure.
I'm sure those tips will help us all in approaching management of intimate partner violence.